Hello, I'm Faith Rogers, host of today's program, COVID-19, Keeping Up with the Moving Target. Thank you for joining us. This activity is jointly provided by the Postgraduate Institute for Medicine, DKB Med, and the Institute for Johns Hopkins Nursing. Today's program is accredited for ANCC, AAPA, and AMA-PRA Category 1 credits. Please visit our website for complete CE information. If you're tuning into our webcast, please click the Claim Credit button on the webinar console. Otherwise, please go to covid19.dkbmed.com, navigate to our multi-specialty episodes, and select the webinar to claim credit. Our learning objective today is to describe gaps in current testing strategy. This educational activity is supported by independent medical educational grants from Gilead Sciences Incorporated, as well as in-kind support from DKB Med. With us today, we have Dr. Paul Auwaerter, Clinical Director of the Division of Infectious Diseases at Johns Hopkins University School of Medicine. He will be interviewing Dr. Yuka Manabe, a Professor of Medicine in the Division of Infectious Diseases, the Medical Director of the John G. Bartlett Specialty Practice, and the Director for Center for Innovative Diagnostics for Infectious Diseases. They will be discussing COVID-19 testing. Dr. Manabe, Dr. Auwaerter, thank you so much for both of your times today. Really appreciate it.
Thank you, Faith, and delighted Dr. Yuka Manabe is joining us for the second part of discussion of diagnosis of COVID-19. And this part will speak a little more about maybe perspectives on how diagnostics have evolved over the pandemic and also the impact of perhaps some future trends. So Yuka, first I might start off. It's been over 2 years since most of us have really grappled with this pandemic virus. What have you seen as important trends or contributions to the area of infectious disease diagnostics in response to the pandemic?
Well, first of all, I think that we've had an unprecedented focus on diagnostics. I think it's amazing that most Americans know the difference between a molecular test and an antigen test. This is something that, or a rapid test, as some of them call it. This is a time very different from in the past. I don't think anybody ever asked, like, which test did you get, this one or this one, right? And I think that that's great. I think that having that kind of knowledge is helpful, I think, for people in our field. I will say that there was a rapid evolution. Remember back in February when we were all worried that it was coming here to America? There were early cases at that time of 2020. Back then, we were relying solely on the public health departments to be doing all of the testing, as we have done for some of these unusual illnesses as they come in when they don't reach the unprecedented levels that we saw with COVID. Back then, when we were relying on the public health departments, there was a huge backlog. You couldn't get a test fast enough, right? You would have to guess at best. And we were waiting and we were getting confirmation many days after sending the test. By May of 2020, private companies had taken on the bulk of that testing, had been able to get emergency use authorization for molecular tests that could be run in any lab. And 99% plus of the testing that was going on was no longer going on at public health departments. And then we continued to evolve. And now we're at this point, because of a real commitment, I think, by the US government to fund diagnostics from the beginning all the way to now, people are receiving rapid tests at their doorstep, maybe not as many as they hoped, and maybe not during the peak of the Omicron virus, but they got them nonetheless, and they got them for free. And I think that we need to be able to make that happen if we ever have future pandemics in a way. I think we've learned a lot from this one to try to help people figure out their status quicker. So the next thing that I see coming is at-home molecular testing, the most sensitive testing, but in your house, you do it yourself. There are challenges to that too, which is it will be expensive. I haven't seen molecular tests that are inexpensive enough, the way rapid tests can be, to be able to give them to every household, for example. But it may allow people to have the most sensitive test in their house. The second is that we might be able to come up with tests that can tell you about more than one thing at the same time. We talked about combination tests in the last one, but imagine being able to figure out if you have flu in your house. And that would be great. The other thing is to try to bring forward some of these platforms where you have direct detection, where you don't have to amplify anything, that you, within, say, minutes or seconds even, you could say it's present, it's absent. And to have those platforms, you're going to have to amplify the signal of I found the virus against the background noise of all the other garbage that could be present in a sample. And I think that if we can increase the signal to noise ratio, we could have some direct detection platforms, the ones that I call beyond PCR, right? Paul, you and I are similar age, and PCR is like kind of the new kid on the block from when we were young. When we were in college, we were first hearing about PCR and started using it effectively. I think the next thing is going to be beyond PCR.
Yeah, and some of those are very interesting, using molecular fluidic technologies and hold at least the possibility of costs being lower. I mean, my father-in-law, bless his heart, is I won't say a hypochondriac, but highly concerned about COVID coming into the house. So my holiday present to him was getting a home molecular diagnostic platform. And that's been very helpful, especially early on, where, you know, Omicron may be negative on antigen testing, and, you know, you don't have to worry about doing serial testing and so on and so forth. So we saw the advantages of having home testing. But to your point, you know, is $70 a test there, which, but for convenience sake, you don't have to find somewhere to go and so on. It may facilitate getting an accurate diagnosis to help a physician that you could just go to a store and get a test.
Yeah, there's 2 points maybe that we want to make about that. One, when you test at home, nobody else knows about the result of that test. So it's difficult for us from a public health standpoint to track how many cases there have been. Many of you may have done a rapid test at home and had a positive, and you didn't tell anyone. You may not have even told your physician. So there's no reporting. So I think figuring out ways to close the loop, to make sure that everyone that's doing those tests that are on the cloud, those get reported in some way so that we know that positives are happening. The other thing that's happened during the pandemic, which I think is really an interesting area, is mail-in self-collection. You self-collect at home the sample, you put it in something, maybe not in anything, maybe it's a dry swab, or you put it into the buffer, and then you put it back into the mail and you mail it in somewhere and they do the test. Then there is public health reporting. You do it from the privacy of your own home, and you can get a relatively rapid result, really only dependent on the amount of time it takes to mail. That might not be very good if you're symptomatic, but if you're worried and you want to just do it from the comfort of your own home, that might be really great. That's also been a shot in the arm for sexually transmitted infections. There's a huge number of STIs that are now being diagnosed in that way. So that's another thing that has maybe been a diagnostic silver lining during COVID.
Yeah, I think those are the kinds of situations where even years ago, home HIV testing, you had a raised concern, but you would then prompt and follow through. But people felt like they could do something in the relative privacy of their own home for perhaps more socially sensitive tests. But one of the things that I struggle a little with, because I do not only infectious diseases, but I have a small primary care practice, is coming to how we used to deal with influenza. We looked at influenza. I said, well, does my patient have a high risk of severe disease or not? Is there a lot of virus circulating in the community or not? But I really did not go and pursue a rapid diagnostic test. I just treated empirically with oseltamivir, for example. But now we may have a landscape with several viruses that have therapeutic options. Do you see a future where we're going to be more reliant on testing than in the past, for example, during respiratory seasons, or do you think people are going to say, well, both viruses are circulating, oseltamivir and Paxlovid are both relatively harmless. I'll just prescribe both, but increase costs that way.
Well, I would say that there's never been a doctor that says, I want less information. If you told someone they could have more information for an inexpensive amount and it was easy, you probably would order it. Part of it is that it's not that easy to get people in, and you also don't want to have somebody who has influenza symptoms in your office giving it to other people. So I think that as the options increase, we also want to try to think about things that are frugal innovation. I hope that some of the cheaper platforms come through and are available to everybody so that having diagnostic certainty doesn't cost so much. And if we could get there, that would also be good for the developing world that certainly can't afford to pay $70 a test to tell if somebody has COVID-19. So these are the areas where I think diagnostics need to go in the future. The other thing is, if you could also put bacterial pathogens in there in addition to viral pathogens, you might want to know, and you might also want to know whether or not they are resistant bacterial pathogens. And as we start to have this ability to have combination tests that can tell you multiple things for an inexpensive price tag, you might be very interested. And those are things that we're thinking about also in the area of STIs. So do you have gonorrhea? Is it sensitive to ciprofloxacin? Could I give you oral ciprofloxacin as an option for someone who can't come in or has some other reason to not want to get an injection? So these types of things, having more information would be better, but there's a cost trade-off. And I think that that's where we're coming. If we can make that price point lower, I don't know, would you want diagnostic certainty if you could get it easily for a low price point?
Yeah, I agree. I could see, I mean, an ideal future might be that you have a rapid respiratory panel at the drugstore. You have a rapid STD panel. You may have a rapid diarrheal panel, a rapid UTI panel. You can imagine these potentially, and it may be something that, drugstores have a little room and you just provide that and they have the reader there. So you can do it. I mean, not, instead of just in your own home. I mean, you can imagine these things becoming much more incorporated. We already see it with minute clinics and urgent care centers where the barrier hopefully is lowered for people to get a test. And you're right, going into doctor's offices, bringing an ill patient in there is something we didn't do during the pandemic.
I think it does bring up the issue of insurance companies, though. Insurance companies have to recognize that that kind of CLIA-waived point of care testing is cost effective. So I think understanding the cost of that test compared to the cost of empiric treatment, they may actually say better to know and to treat specifically for what you have. And I think that exposing people to less unnecessary medication is certainly something that we all strive for. So I do like that pharmacy model. I will say that pharmacies are coming under pressure now. You're gonna do everything in the pharmacy. So at some point, pharmacies aren't going to be able to handle all of this work. And we're going to need to have more people and more space devoted to that. And you have minute clinics, but you might have minute diagnostic clinics that will be slightly different. But insurance companies are going to have to recognize that as having value. Otherwise, they won't pay for it. If they won't pay for it, if no one's going to pay for it, I don't know that I would spend $100. I would tell my doctor, just prescribe me something. So I don't think people are going to go out of pocket for that. So at some point, if that's considered part of quality healthcare and it gets paid for, that's going to be important. So this is a regulatory landscape that I think is going to get complicated, but is important to work through.
Yeah, absolutely. I think you make some exceptionally solid points on this that need to be carefully worked through. And there needs to be advocacy, I think, so that diagnostic companies don't feel like there's a limited market ahead because it's a self-pay option compared to being incorporated as part of their insurance coverage.
Yeah, and just so you know, there's only 2 states right now, for example, for STIs that will cover mail-in self-collection. It's California and hopefully Maryland. That just came to the state legislature this term. And so I think there's a recognition that we might be moving in that direction. But if you think about the continental United States, it's still very few states that are recognizing that it's important. But asking if you are a covered person with insurance, that this kind of mail-in self-collection ought to be covered by insurance companies so you can know your status. It'll be interesting to see how this plays out.
Yeah, I agree. And perhaps as you started off this segment, the raising of diagnostic awareness, not only of the patients and the general public, but even of physicians. I mean, I think back to 2019 when I really had to explain the difference in a rapid influenza diagnostic test versus a molecular test and how they differed. Becomes incredibly easy now in this particular case. The last few years have brought tremendous advances. Yuka, in closing, what are some of the gaps or the needs that you think that we should be thinking about, not only as individual practitioners, but even within the diagnostic community, as working with either regulatory agencies, funding from the government, or insurers?
It's a big question, but I think the main gaps are keeping an eye on cost. That trying to make sure that people start with the end in mind. So developers should be developing things that we can afford, not so they can have the largest profit. Second, keeping an eye on the diagnostic prize, making sure that we're targeting the right things to be diagnosing and making sure we're not just getting information that we can't do anything about. And sometimes something that you can't treat is okay to know, because then it may save you from giving antibiotics, for example, to somebody that didn't require them. And then finally, trying to have some equity of access, right? We saw great inequities during COVID-19 pandemic. And right now we know that there's inequitable access to diagnostics. People who have insurance might have an easier time getting. We should make sure that we have equal access, not just here in developed countries, but also in the developing world, where diagnostic certainty comes at a much higher price and often is it's foregone altogether. They don't bother. And so I think that thinking about access as we have with vaccines and everything else should also apply to diagnostic access. And finally, that innovation without access is really not innovation at all. So again, starting with the end in mind, making things that are innovative but also can be available. I hope one day we get to the point where you remember Star Trek, where Scotty would just wave a wand over and tell people what they had. I mean, we're not quite there yet, but wouldn't it be great to walk through an archway that's detecting whether or not you might have one of these viruses and flag and say, maybe that person should not go into that arena. And I think that we are starting to see breath tests for volatiles, for direct detection, many things that I think are really exciting. I personally am super happy that this is what I decided to do with my life. I think that diagnostics are going to have their day and be an important part of the armamentarium of physicians and other care providers.
Yuka, I want to thank you for all your comments and agree that the pandemic has raised the profile of diagnostics, and having someone with your expertise, I think, is just critical, and hopefully the advocacy to also make lives better for our patients and also easier within the medical system by many of the aspects that you raised. So thanks so much, and thank you for the audience for listening to these two programs.
Well, thank you again to both of you for your time. We certainly do appreciate it. If you're tuning into our webcast, please click the Claim Credit button in the webinar console to attest for credit. Otherwise, please visit us at covid19.dkbmed.com. Again, thank you for joining us, and thank you for your dedication to your patients with COVID-19.